disability, and which is responsible for 7.3% of all year-lived disability in most of the patients. And age group affected is 30 to 50 years. So most economically productive age group is suffering from this condition, and so it is actually causing a significant cost in the healthcare and productivity loss, especially in the high volume countries. Now coming to the scenario of India, the number of studies in the Indian scenario is comparatively less, but the data what we found from the Indian scenario is that the lifetime prevalence of the low back pain is between 50 to 80%, with 23.9% experiencing it at any given point of time. There are the occupational factors which can actually increase this condition, like manual labors in rural areas, or in case of sedentary desk jobs also in the urban settings are the major contributors for the low back pain. And there are limited access to the pain management, particularly in the rural areas, lead to chronic disability. Now, this is a fact and this is true that even though we are getting so many low back pain patients, if I just leave those patients, 90% of those patients will actually be resolved spontaneously within 4 weeks with or without a treatment. And rest 10% which are not being able to recover them spontaneously, they are actually the major challenge in the pain management, especially in the chronic pain management. Now the question comes, if I say 90% of the cases will resolve spontaneously, then can we wait for all patients? The answer is definitely no, because we have to manage those cases, and especially we need to pick up those cases that are actually dangerous and we have to treat them urgently and early. So what are those cases? They are called the red flags. Now let us see what are the red flag signs in pain management. First of all, low back pain, which is happening after a major trauma. So there could be a possible fracture, and that is one of the important markers that these patients should not be waiting for a spontaneous recovery. We have to investigate them and we have to find out whether any major fracture is there or not. If it is not there, there is no problem. You can wait. You can give some analgesic and wait for some time for the spontaneous recovery to occur. But if it is having a specific problem, then we have to treat them as early as possible. Next is the suspected infection. If the low back pain is associated with the high grade fever, if low back pain is associated with the neck rigidity or other systemic symptoms, then you should always investigate them early, because that could be a possible sign for a bacterial or a tubercular infection, or sometimes it could be a viral infection as well, but that is usually not that major. But especially if it is an abscess causing pain or if it is discitis causing pain, these are the suspected infections that is actually falls under the category of definitely red flags, and you should treat them early. If there is suspected tumor, for example, there are history of recent weight loss, or there is severe night pain, so that could actually say the patient might have a suspected tumor, and in those cases we have to investigate them early. Patient with the neurodeficits, either autonomic, motor or sensory, so in those cases if the patient is having progressive neurodeficit, we should consider them as red flag and we should treat them immediately. And there is another point also, that severe pain. Usually severe pain can signify other conditions. Remember, as a main cause, severe pain is not a red flag, but severe pain can indicate that other causes might be there. So you should take those cases also seriously. But remember, as a whole, severe pain is not a clean red flag like the others, but when the severe pain is there, you should suspect that the causes what I have mentioned in the red flag might be there, and we have to investigate those cases as well. But otherwise, you can give the NSAIDs or you can give the paracetamol and then wait for the spontaneous recovery. So what as I told, the remaining 10% of this adult represents the one of the greatest challenges to the conventional pain management. So out of those patients, that means the whole patient was 100, 90 recovered spontaneously with or without treatment or a short course of NSAIDs. Rest 10%, among those 40% of the patients usually recover with alternative modalities of therapy. What are those? Like physiotherapy, psychotherapy, rehabilitation. So with those, they are also recovering with time, but approximately 5 to 6% of the total sufferers, they are the major challenge because they actually land up in one or more major surgeries and without getting a pain relief, sometimes without a definitive cause as well. And majority of the sufferers is not having any identifiable pathophysiological cause with the conventional investigations, including CT and MRI. So it appears a little bit surprising, but it is true that even today we say MRI is something that is very sensitive and that can pick up very small abnormalities. But in low back, there are a number of cases where we will found that there is no correlation between the pain and the MRI finding. Similarly, the opposite is also found. That means a number of patients will be there who will be asymptomatic with MRI changes. Okay, so MRI correlation is very poor and it is around 40% only, both CT and MRI. So that is one of the biggest problem in the low back pain. So it has been found that as much as 90% of the low back pain, the source and pathologic mechanism is not known. There is poor correlation between the pathophysiology and the clinical finding in spinal pain, and psychological factors and the central pain pathway factors. These are the main reasons for this poor correlation between the pathology or tissue damage with symptom. Now coming to the recent researches, it has been found that a large proportion of the patients with the low back pain develop secondary depression. Nociceptive pain sources can be regularly identified in these patients suffering from the low back pain, and successful treatment of the low back pain can revert these abnormal psychological profiles to normal profiles. So that is the important part and that we should target for. Next, we will be discussing the structures that could be the pain generator or the structures that are responsible for low back pain. So, let's start to see the spine and let us see the structures which could be the possible pain generators in the spine. So, if we look at the anterior part of the vertebral body, so there are the discs and the vertebral bodies. Disc can cause two type of pain. When their problem is restricted within the inner layers of the annulus, this is known as the discogenic low back pain. So this can cause a type of back pain without prolapse, and this is known as the discogenic low back pain, or sometimes it is also known as the internal disc disruption. So I am just asking you to remember one term regarding the disc, that is the discogenic low back pain, and which is the result of the internal disc disruption, where the outer annulus, we all know that disc is mainly having the two layers. The outside layer is known as the annulus fibrosus and the inner layer, can anyone tell?
Nucleus
Nucleus
pulposus.
pulposus. And nucleus pulposus, Dr. Aziz is writing multiple times there is no audio available, but I think the audio is available to everyone. So please check your this thing, computer speaker, And Chinmada, please write him a message on that because he is not able to hear probably. So one thing is important, that here what is happening in this outer nucleus layers, usually which is composed of collagen fibers crisscross sheets, which are usually arranged in a layer of 16 to 25. Within these layers, some cracks, fissures, they appear, and they can become the source of pain because of the generation of the small nerve fibers. Okay, and that is what is known as the discogenic low back pain. I will come to the detail of it, but remember, discogenic low back pain is a new term probably for all who are not in pain management, but we should remember discogenic low back pain is unlike a common radicular low back pain, that is a radicular low back pain. But you will be surprised to know that discogenic low back pain constitutes of more cases, and it is the commonest cause of low back pain in young patients in comparison with the radicular pain, which is we aware of more, but that radicular pain is comparatively much rarer in incidence than the discogenic low back pain. So what is radicular low back pain? When this disc bulge either mechanically compressing the root or the inflammatory materials from inside the disc. You should always remember that nucleus pulposus is like the lens of an eye of our eye. So it has not come into the contact of the immune system of the body. So when it comes out here, they can cause a strong inflammatory reaction or a mechanical compression, both can occur, and that can cause a pain and inflammation, that is a herniated disc pain, or that is radiating to the legs. Okay, that we are more aware of, that is the radicular low back pain. So disc can be a cause of pain. It can cause either a low back pain which is restricted to the back and which is known as the discogenic low back pain, or it can cause a radicular low back pain which is really going to the legs. Now the vertebral body, can vertebral body be a cause of pain? Definitely. When there is a fracture, it could be a osteoporotic fracture, it could be a metastatic fracture, it could be a traumatic fracture, that can be a cause and source of the pain. So that comes to the anterior part. So in the middle part, what we have, so if I roughly draw a line, for example, just try to draw a line here, and if we see, so we are just drawing a line. So portion anterior to this we can call, these are mainly causing the anterior pain. Now we are coming to the middle column. So in the middle column what we have? We have mainly the foramen, and slightly posterior to it we are having the facet joints. Okay, so that can be a source of the pain. The foramen, I have already discussed one issue, that is the radicular pain which is arising because of the disc. But sometimes there could be an osteophyte in the foramen, and that can compress and cause inflammation at the root, and that can be a source of the pain. Or sometimes it might happen that one vertebra is moving over the other, which is known as the spondylolisthesis, which can be a traumatic because of the fracture at this area, which is known as the pars intra-articularis, and one segment moving ahead or behind, causing a pressure over the nerve root. So that can also cause a pain originating from the foramen and originating from the nerve root. It is possible. But the more common is this facet joints. Remember, like all other joints, say a knee joint, facet joint are the small joints, they are synovial joints, they are paired joints. So where are those facet joints? Let me show you a model so that it will be easier for you. So here if we look at the facet joint, okay, spotlight for everyone, okay. So here we have this small facet joint. See, these are the small facet joints, these are the small facet joints. Can you see? Just close to the tip of the pain, and these joints are composed of the superior articular process of the lower vertebra and the inferior articular process of the higher vertebra. They are forming a joint at the back of the spine. So this side one pair, one and this side one, so they're becoming a paired joint. So our body weight is being transmitted by the vertebral body and the disc in the anterior side, and the anterior and the posterior side by those facet joints. Usually the 80% of the body weight is transmitted by the anterior compartment, 10% from each side, so 20% total. So 10% is passing over the facet joint, but it changes depending on the posture of the person. So if some person is sitting, or some person is standing, or the person is lying down, the ratio of pressure definitely differs from patient to patient, and they will change. So these facet joints can be a source of the pain. How? So there may be inflammation which can be caused by a trauma. An inflammation can be caused by of degeneration, or an inflammation that can also be caused by another condition which is known as the inflammatory arthropathy. For example, the patient is having, a male patient, young, 20 to 40, suffering from the pain in the back along with sometimes the redness in the eye. So you can think of a case of the spondyloarthropathy that can cause multiple facet joint pain and multiple inflammation in the facet joint. So that could be a source of the pain. So there are multiple areas where actually facet joints can be inflamed, but it is most common in the aged group, and those patients, aged patients, they are actually having the degenerative facet joint pain. Okay, so they constitute another major component of the back pain patient. So as we see from the younger perspective, so here the most common cause for the low back pain is usually the discogenic low back pain. But as it goes older, the most common cause of pain is the facetogenic low back pain or the facet joint pain. Okay. Someone is asking to show a little bit of 3D anatomy, so it will be easy. So let us show them a 3D anatomy. So just one second, I am opening the 3D anatomy software. Okay. So I am just sharing so that it will be easier, because models are not usually visible great in the online. So here we are having the spine of a patient. So what we are having, as we are telling, so let us hide a few structures so that we can clear up this area and we can see those better. Okay, I am hiding also the ilium bone. Okay, oh, but okay, so let us come. So as I told, in the anterior portion, remember, not we are just discussing about the mainly the bone and the discs, but and the roots, but there are some fibrous structures that will come along also. This is the anterior longitudinal ligament, let us hide that, and behind there will be the posterior longitudinal ligaments as well. So we'll be hiding those. These are the transverse ligaments. They are basically stiffening structure of the facet joint. So let us hide a little bit of these ligaments. Definitely they can be a source of pain as well sometimes, but though we are coming to the most common causes, so let us show that. Okay, so as I told, these are the anterior portion where we have the vertebral bodies and the discs. These portions are the pedicles. I am just hitting over my cursor, you can see. So these portions are the pedicles. They are connected to this area. So this area where a number of structures are meeting together, they are known as the pars intra-articularis. So in the pars intra-articularis, which structures are meeting? So from the anterior side, meeting the pedicle. From the lower side, meeting the inferior articular process. From above, it is meeting the superior articular process. From medially, it is meeting the lamina. So a number of, from lateral side, it is attaching with the transverse process. So a number of structures are attaching in this area, and this is the pars intra-articularis. Okay, and these are the small projection. Here is a mammillary body and accessory body. I am not going into that much detail here because that is not required, but these are the important parts of a spine. So initially I discussed about the discs and the intradiscal origin of pain like a discogenic pain, and when the disc is prolapsing and causing pressure over this root, or causing inflammation at the root, causing pressure to the nerve and causing pain which is dermatomal distributed, and this is known as the radicular pain. Now we have discussed about the vertebral compressions and as well as the fractures of the vertebra because of the trauma or because of the malignancy. Next we have discussed about the root, and then we have discussed about the facet joints. So facet joints, like all synovial joints, is having the capsules. They are also known as the zygapophyseal joints, but in easier term we always say them facet joint. So here are the capsule of the facet joint, and also one thing you should remember, the anterior part of the capsule usually blends with the ligamentum flavum, so that if accidentally you are going and crossing to the anterior side, you can actually cross the ligamentum flavum. And within this joint, I am hiding this as well, this capsule as well, so that you can see actually the facet joint, they looks like this. So they have the synovial surfaces over it, okay. So they are joining one another, and when they are having pain, so basically they are becoming arthritic, and they cause the pain like a knee arthritis, and this is known as the facet joint arthritis or facetogenic low back pain. So it can be caused either by the trauma, either by anatomical anomaly, for example the listhesis, it could be congenital, it could be traumatic, okay, it could be degenerative, so that can cause this type of condition, or it can be inflamed by the inflammatory processes as well, and that can cause the pain as well. So these are the facet joint arthropathy. Then what are the other structures that can cause pain? So what are the muscle here just behind this? Can anyone remember? What are the muscle just behind these structures at the back?
Quadratus lumborum.
Yes, quadratus lumborum is not one muscle. Basically, there are three muscles. That is the iliocostalis, multifidus, and the longissimus. Okay, so they are actually all three together are called the quadratus lumborum. So they are remaining just posterior to this area, and yes.
Erector spine.
So sorry. I'm really sorry. So this part is erector spinae, quadratus is lateral. Okay, so here just behind to this, it is the erector spinae group which is having these three muscles. Sorry, okay, I got lost the flow, lost in the flow. So here are the erector spinae group of muscle, and just by the lateral side there are the quadratus lumborum group of muscles. Okay, so quadratus lumborum. So this part will discuss with the USG, because if we go into that part, then it will become more difficult. With time we will learn everything. Okay, so here it is not the quadratus remains in this side, and anteriorly there is the psoas, and here it is the erector spinae, and there are three components of the erector spinae. One is the longissimus, one is the multifidus, one is the iliocostalis, among which the multifidus is the deepest and the deep group of muscle, and they are supplied by the same nerve as the facet joints. Okay, that we should remember. These are very important. Now there are some important ligaments as well. So here we have the supraspinatus ligament, here we have the interspinatus ligament. Okay, so here it is going over the spine, here it is going in between the spine. So when there is inflammation here, and the ligament can also cause inflammation, and which can actually cause pain. So from the posterior side after the facet, it could be the intraspinous ligament inflammation or supraspinatus ligament inflammation. Intraspinous is more common, or there could be muscular spasm. We should not call it a muscular spasm, rather there is a specific term which is known as the myofascial pain syndrome. There is development of a taut band within the muscle. There are certain mechanisms on that, and there are a few large books on this myofascial pain as well. It is invented by Janet Travell. So these are the conditions that can affect the muscle and that can cause the pain. So that could be another cause of the back pain, which is posterior to this area. But remember, it could be a solitary event that without any spinal problem it might happen, or with the spinal problem, existing spinal problem, there could be inflammation here, and that can cause the myofascial pain, and that cause the pain for the patient. So let's be back to the presentation. Okay, let's start. Okay, so here actually we are moving back. So what could be the other pain generators? Remember, in the lower part we have these important areas. So here we have the ilium, here we have the sacrum, and here we have the sacroiliac joint. Okay, so this sacroiliac joint can be a cause of the pain. And remember, in certain disorders like spondyloarthropathy, this is the common source of the pain. In fact, if you see the guideline for diagnosing a spondyloarthropathy at its early stage, it is the MRI of the sacroiliac joint to find out the evidence of sacroiliitis. So, sacroiliac joint can be a source of the pain, which could be because of one condition, that means inflammatory arthropathy, or it could be traumatic following a fall, or it could be associated with the disorders of the leg. For example, a congenital limb length anomaly. So what it can cause? It can cause the differential distribution of the pain among the sacroiliac joints and facet joints as well. So they can cause the areas or the joint that is having more pressure, or they are having the more pain over, they can easily go for a sacroiliitis. Okay, or it could be infective sacroiliitis. It could be possibly because of any leg disease. For example, someone is having a pain in one leg, say because of an osteoarthritis. So what happens? Again, this distribution of the weight in the both the sacroiliac joint differs, and they can go into the sacroiliitis as well. So the sacroiliac joint can be a cause of pain. Then there could be another cause of the pain because of the muscle. So just over the sacroiliac joint there is a muscle which is known as the piriformis. Piriformis takes origin from the anterior portion of the sacral 2, 3 and 4 foramina. So here from the anterior side the piriformis muscle takes origin and attaches near the greater trochanter of the femur, and that is actually moving over the sciatic nerve. So if there is spasm or myofascial pain of this piriformis muscle, that can put a pressure over this sciatic nerve, because sciatic usually goes below the nerve. There are 5-6 patterns by which sciatic can emerge with this in relation to this muscle, but most commonly it emerges below the nerve, and if there is a spasm in this muscle, that can put a pressure over the formed sciatic nerve, which can cause again a leg pain. Okay, and this is known as the pseudo sciatica, because the term sciatica is usually attached with the radiculopathy, where only single root is involved and pain is going to one leg. But when it is happening after this formation because of the excessive sacroiliitis or because of the piriformis syndrome, they are compressing over the sciatic nerve and that is causing pain. The condition is known as the pseudo sciatica. That could be a source and cause of the pain. But remember, previously the term was specifically piriformis syndrome, but nowadays it has been found that there are 3-4 more muscles just below the piriformis. What are those? Superior gemellus, inferior gemellus, and in between there is the obturator internus, and just below there is the quadratus femoris. So they can also be a source of the pain because sciatic is moving over them. So nowadays they all term together under a single name, which is known as the deep gluteal syndrome. So basically, gluteus maximus is the covering muscle in this area. Under the gluteus maximus, the pathologies are compressing over the sciatic nerve, and this is the deep gluteal syndrome, including the piriformis syndrome, which is previously known of, and they are known as the source of the pain and causing the pseudo sciatica to the patient. Now, why the pain physicians are unique here? Because we can perform some special investigations. Okay, apart from the conventional investigations like an MRI, CT scan, bone scan, or X-ray, we can actually find out the real cause of pain where those investigations cannot show that pathology. So what are those? For example, for simply you think if it is a pain originating from the facet and which is not picked up by the MRI, then what we can do, we can suspect a pain originating from a facet joint and we can inject a small volume of local anesthetic within that joint, and then what we come the result, if the pain is gone, we are sure that this pain is originating from that facet joint. So it is basically a facetogenic pain. So that is how we can go for a diagnostic facet joint block. So it can be blocked either by going within the joint, or we can block the nerve supply to this joint so that we can make sure and understand that it is originating from the facet joint and we can treat accordingly. Then there is a technique which is known as the provocative discography. This is for the discogenic low back pain or the internal disc disruption, where the artificially increasing the interdiscal pressure, we are actually trying to find out that, excuse me, any question please? Okay, if there is no question, please mute. Okay, so what is happening here? It is actually increasing the interdiscal pressure artificially, and that can cause or provocate the pain which is originating from the disc. So for the discogenic low back pain, we can go for the provocative discography. Then there could be epidural adhesions causing the pain. That can be picked up by the epidurogram or by the spinal endoscopy. Or if there is a radicular pain and we are not able to understand whether this root is involved or not, whether it's a radicular pain or not, what we can do, we can go to that selective nerve root. Say it is a L4 left-sided root. We can go to that nerve root and then we can inject a very small volume, say 0.5 cc of the local anesthetic in the root, and ask the patient whether the pain is relieved or not. If the pain is relieved, the origin is the L4 root. So in that way, we can actually find out. Similarly, for the sacroiliac joint, we can go inside the sacroiliac joint and we can inject small volume of the local anesthetic, and if it gives relief, then we are sure that it is originating from the sacroiliac joint. Similarly, if there is a lower limb complex regional pain syndrome, okay, so what is complex regional pain syndrome? So it is a pain condition which is complex and which is taking origin after an injury to the nerve or to that organ, okay, and that is not matching with the inciting event. That means that it is not disproportionate to the inciting event. That's a special type of pain and which is mediated by the sympathetic nerves, or it is originated by the sympathetic nerves. They are known as the complex regional pain syndrome for the lower limb. So we can go for the sympathetic nerve block to find out whether the pain is from the complex regional pain syndrome or not. Or we can go for the differential spinal and epidural block. That will come later and we'll discuss that again after a few classes. So that is known as the differential spinal epidural to find out the source of the pain. So a number of diagnostic procedures we can do to find out the cause of the pain, and it has been found after these processes, or I should say diagnostic procedures, those patients who were not able to identify what is the source of pain, it has been found that depending on the studies, this ratio differs slightly because depending on which population it has been done. The facet joint pain is around 40%, discogenic low back pain is around 26%, sacroiliac joint pain is around 2%, segmental nerve root pain is around 13%, and even the no cause identified in 19% of the patients. So it's a way by which we can actually increase our ability to diagnose the disease and we can find out the cause of the patient. So this is the data which we found from the multiple studies. So facet joint arthropathy can constitute according to the different studies something between 15 to 45% cases of those patients Internal disc disruption can be the source of the pain in around 25 to 40% patients. Sacroiliac joint arthropathy can be caused around 15 to 30% of the cases. Disc prolapse, herniated disc or slip disc can be caused by 2 to 5% of the patient, and the CRPS is around 2 to 8% of the patient. So these are the major and common causes of pain. Remember, let us see what are the uncommon cause or the rare cause. So osteoporotic compression fracture can be attributed a range of 3 to 5% among those patients. Fibromyalgia or myofascial pain, that could be among again 2 to 5% of the patients. Spondylolisthesis, 2 to 3% of the patient. Infection, less than 1% of the cases. Other fracture, less than 1% of the cases. Spinal canal stenosis in 2 to 3% of the cases. Tumor, less than 1%. Other rare conditions like Feldback surgery syndrome, that can be less than 1% of the patients. So if we get those patients, then we should diagnose the common conditions commonly so that we could be more right, but definitely we should not be missing the red flags. That is the most important message throughout my lecture. Okay, so first important is you should not miss a red flag. Then let us try to know the diseases or causes of those pains individually. So facet joints, as I told, it is at the posterior part. And remember, in facet joint pain, usually the patient is having more back pain than leg pain. So back pain is more than the leg pain. Facets are situated by the side of the midline. So there should be pain either in the left or right side of the midline, or sometimes if both the facet joints at a level is involved, it could be appear as midline pain, but in general if one side is affected, pain will be on that side. Pain will be increased by the maneuvers but increases pressure over the facet joint. So facet joints are at the posterior side, so the patient will be lean back, the pain will be more. So pain increases on extension. Patient will be rotating, usually in rotation the pain will be more, in lateral bending the pain will be more. And remember one thing, the patient usually complains that when I am sitting the pain is less. As I am sitting to standing, remember in sitting our spine is usually curved more anteriorly. When we are sitting to standing, usually pain appears in the facet joint. They start working, initial part the pain is usually less. As they increase their walking, the pain usually increases. When they changes the side in the bed at night, usually the patient complains of pain increases. Okay, so these are the common areas and common maneuvers on which the facet joint pain increases, and patient usually states that. And usually, as it is an arthritic pain, like all arthritic pains, if the patient is at rest, usually there is no pain. Pain is related to the movement. And if there is a inflammatory facet arthropathy, then what will happen after taking a rest, when the patient will start moving, the pain will be more. That is one of the characteristics from all inflammatory joint pains that applies to the facet pain as well. And as it is not causing pressure over the nerve, so it will not be following any dermatomal distribution pattern, like the radicular pain will not be there. So that is one of the important message here as well. Now, so what we can do? So in facet pain, for a short-term pain relief or the diagnosis, we can inject the dipomethylprednisolone inside the facet joint. But for the long-term pain relief, we can actually go for the radiofrequency rhizotomy, by which we can actually block the nerves. Just there is a lecture of the radiofrequency already given to you. Just listen to that lecture as well, then we could be understanding about the radio frequency. Okay, so we can do a radio frequency rhizotomy. Either it can be a conventional or pulsed, but here in the facet joint we prefer the conventional type of radio frequency, so that we can actually burn those nerves supplying the facet joint at around 80 degrees Celsius, and we can numb those joints. Okay, and that can give a long-term relief. And this is the usual location under fluoroscopy where we have to block, and it is known as the eye of the scotidor. Today it is mostly discussing on the clinical part, so we will not be going into the detail of the scotidor or how is the eye, but definitely when we learn the facet joint arthropathy and its management, we will discuss in detail about the anatomy, especially the fluoroanatomy, and we'll discuss about this location of this nerves. So that is how a median branch rhizotomy is usually carried out. Now coming to the disc. As I told, there could be two conditions. One is the disc disruption and one could be the disc prolapse. So as I told, there are two layers, inner nucleus, outer annulus, and above and below lies the vertebral end plate, and there are 16 to 25 layers of the collagen fibers which remain at 90-degree angulation like crisscross like fashion. So they like this kidney shaped discs. Now what happens? Whenever there is increase in pressure, one thing you should note that only outer part, one-third of the annulus is usually supplied by the blood vessels and nerves. Usually the middle third and the inner one-third as well as the nucleus is not having any nerve tissue. Okay, so usually even though there is increase in pressure, it doesn't cause any pain. But when the disc gets degenerated, okay, so when the disc is getting degenerated, then what will happen? Then the condition is known as the discogenic lobe appointment. So it was the clear picture. As it is more degenerated, you see cracks and fissures are appearing, and these are the MRI change which is corresponding with the change. So that the initial part, when the water content in the nucleus is more, this is the normal condition and normal contents of the water. Usually nucleus pulposus contains 77% of the water, annulus contains 70%, and end plate contains further low around 50%, 5% of the water. But as the disc is degenerating, the water content reduces inside the disc, and now initially under the titubated image we are seeing the water as white, but as we are going further it will become more blackish. Okay, so that is how the degeneration changes it, and there will be cracks and fissures along with the new angiogenesis. Some nerve endings proliferate inside it. So previously there was a normal disc with no nerves, but now what is happening? Some abnormal nerve fibers, they are going inside along with free nerve endings and ending. And from where this nerve comes? They come from two areas. One is the gray rami communicants of the sympathetic nerve, which are actually coming from the sympathetic chain to the main nerve root to be supplied to the organ, and the other is the sinovertebral nerve. Mainly they are the sympathetic nerves, they are going to the disc. So as they are sympathetic nerves, so the pain will be like the visceral pain. So what are the characteristics of a visceral pain? First important characteristic is that they are poorly localizing, so that the patient won't be able to tell. Similar to the say, if the patient is having a kidney pain or a stomach pain, can the patient tell my stomach is paining or my kidney is paining? So he will say I am feeling pain in the back. So similarly, here the patient won't be able to localize precisely from where the pain is coming, because it is mainly carried by the sympathetically mediated nerve. So it will be a visceral pain type of character, and the pain will be increasing on forward bending or the maneuvers that actually putting more pressure over the disc. So at the initial part, when the disease is at the early stage, then the patient will be feeling pain when he is actually jumping or the patient is actually putting heavy load over head. So in those conditions only he will be having the back pain. But as the disease increases, the sensitivity of this nerves also increases. Now the patient will be having pain while the patient is sitting with the forward bends. And with time, the pain will be so severe that the long-term sitting without support becomes painful, but the pain gets relieved when the patient lies down over the bed, because the pressure on the disc is reducing. So the pain is also relieving. So this type of pain is known as the discogenic low back pain. So few important characters of the discogenic low back pain is that it is a predominantly back pain, not radiating. It can be referred, but it is not radiating. Number two, here sometimes the patient's pain increases on forward bending. It is a poorly localizing type of pain because it is sympathetically mediated pain, and usually the patient's pain is relieved when the patient is lying down posture. So we have to understand between two of these terms. One is the discogenic pain and one is the internal disc disruption. So in discogenic pain, what happens? I'm just discussing because I am assuming you have some idea about the degenerated disc, in radicular pain. So in that way, I am just differentiating between radicular pain and the discogenic pain. But before that, we can do one thing. We can go and we can actually know a little bit about the radicular pain so that we can come back. It will be easier for you to understand the comparison. So what is happening at the initial part? There is disc degeneration. With time, there is prolapse because of the internal pressure increases and the cracks appear in the outer layers. Now the disc becomes bulged out like a balloon and it is the disc prolapse. Now as it is increasing further, then it becomes open and the jelly material comes out, that is the extrusion. And if with the extrusion there is upward or downward movement, we call it a superior or inferior migration. And when the material is losing contact with the body from where it came, we know that as a sequestration. So this extrusion, prolapse, extrusion and sequestration stage is no longer restricted within the disc boundary, rather they are going away from it, causing foraminal inflammation and pain, and causing a pain which is nature and character is totally different from a discogenic pain, and this is known as the radicular pain. So what are the important characters of the radicular pain? The pain character is dermatomal. That means if the S1 root is involved, it will be going from back of the leg and it will be going up to the little toe. If it is involving the L5 nerve root, it will be coming along the side and then it will be coming to the great toe. Similarly, L4 will come here, L3 will come here, and if the compression is severe, along with the sensory disturbance, patient will feel the motor weakness of the respective muscles as well. Okay, so herniated disc can cause nerve root compression, causes pain as well as neurological deficits in the form of motor deficit, in the form of autonomic deficit, and pain as well. It is dermatomal distribution, radiating along the affected nerve. Pain pattern, the leg pain is more than the leg pain. Remember, there in a number of patients we have to make the patient understand that your primary pathology is not at the leg, rather it's at the back. Because a number of patients comes to us with the leg pain and they tries to ask us that investigate my leg, the pain is coming down from here, why are not you investigating the leg? You are asking, you are checking the back and you are asking for a back MRI rather than the leg pain, because here the leg pain is usually more than the back pain. And in some patients we have found absolutely there is no back pain, the pain is only radiating pattern. So that is very important for you to judge and understand and make the patient understand that the origin is not at the leg, rather it's at the back. And the incidence is comparatively low if you compare with the discogenic low back pain, which is much more commoner than this radicular pain. So radicular pain is around 4% of the population is affected, and it is usually the lateral pain, and usually there could be a straight leg rising test positive. Usually the patient is supine, you put the leg up slightly one leg. If it is below 30 degree, then you should suspect, it's a high suspicion of there could be possible straight leg rising positive, and up to 60, if more than 60 the pain arises, it is not that significant. So there should be stitching on the sciatic nerve and that is causing pain at the nerve root. And there could be neurological deficit in the form of muscle weakness, so you have to check the muscle power. Negative symptom like numbness may be present, as well as reflex changes could be present, and diagnosis is on the basis of the clinical examination and MRI. Now with this knowledge, let us go back to the discogenic pain. So what happens in the discogenic pain? Here the pain nature character is different. So here there is no nerve root compression, no impingement in the spinal nerve root. The pain distribution in discogenic low back pain, when the disc is not bulged outside, it is not compressed over the nerve, it has not caused inflammation in the nerve root. Here, the back pain is more than the leg pain. It is predominantly back pain. Incidence is
Sir,
approximately 40% cases involving the axial pain. Yes,
actually, sir, that is that degenerated disc can also become herniated disc also, no, sir?
it's a spectrum. So at the
No.
initially it can start with the degenerative disc and
Uh,
then gradually progress towards that. That
so,
cannot.
so discogenic back pain can convert into
Yes,
that.
in long term, not in a short term, but in a long term, definitely it can get converted. Okay.
Okay,
So
sir.
when it opens and ultimately the material comes out, then definitely it can be converted into back pain, or even with the bulge when the mechanical. So actually, there is a stage in the
Yes, sir.
discography. At the
Yes, sir.
early stage, when only the disc is involved, we call it a chemically sensitive disc. But when
Okay.
in discography, we got a PSI between. I will discuss those with the discogenic pain because they are again another chapter altogether. Okay.
Okay, sir. Okay, sir.
So
Sir,
definitely.
also please put some light on differences between discogenic pain and facet joint pain.
Yes, that will I also discuss. No issues. Okay, but these are originating from the disc. Facet pain is usually slightly different as it is more of an arthritic pain. Did this? So let us come with this. I will compare with the facet pain as well. So here approximately facet usually predominantly old age. Here it is usually younger age. Both restricted to the back. Facet precisely localizing the discogenic pain is poorly localizing. That is one of the unique feature of the discogenic pain. Next, ASLR test is only positive for a radicular pain. It is neither positive for a discogenic pain nor positive for a facet pain. In facet joint pain, the pain will be increasing when there is rotation, when there is backward bending. Here, it is increasing when the patient is forward bending, and the radicular pain increasing when you go for the straight leg rising test, as well as in the forward bending also. Okay, that also increases. Neurological deficit will not be there in facet pain. It will not be there in the discogenic pain, but it might be there in case of radicular pain. There is also a term difference between a radicular pain and a radiculopathy. Usually, when the radicular pain is mainly restricting only sensory symptoms, it is known as the radicular pain. But when it is affecting the motor as well as reflexes, is usually called a radiculopathy, though sometimes both terms are used interchangeably. And diagnosis, usually the diagnosis of a radicular pain commonly done with the MRI, we can find out the disc prolapse, but here MRI can also show some signs, like one sign, important sign is known as the high intensity zone in the MRI, and it looks like this, where a pearly white spot in posterior annulus is present, which is highly signifies that it could be a discogenic pain. Similarly, in a very small number of patients in X-ray, also some gas shadows inside the disc can be seen, that also a significance that the patient might be having a discogenic low back pain. So remember, in discogenic low back pain, it is restricted within the disc. It is not causing a pain which is carried along the nerve root. It will not be distributed dermatomally, and in facet pain it will be sharply localizing. In discogenic pain it should be poorly localizing. In radicular pain it is a primary neuropathic pain. In last we have discussed related about the neuropathic pain. Remember, the nature character of pain in case of radicular pain is a primarily neuropathic pain, whereas in both the other cases it is nociceptive pain primarily. Then with time it can get some mixed or a little neuropathic character. Now, for discogenic pain, this is one of the instruments is used for the discography. That is, by artificially increasing the interdiscal pressure with this instrument, we can find out that the disc pain is originating from it. Though it was a very popular investigation in past, but nowadays it has lost its relevance somehow. That's why I will discuss with those cases. Now, coming to the treatment options. So the treatment options for the internal disc disruption is the iDET, nucleoplasty, laser discectomy, conventional radiofrequency lesioning, pulse radiofrequency lesioning, percutaneous discography, ozone nucleolysis, ozone discectomy, surgery, fusion, disc displacement. Altogether, if you see, it's a big list. Why? Because in discogenic pain is a little very difficult to tackle. In fact, even a number of procedures, the desired result is usually not obtained, and most of the cases the result is usually short lasting. That is why so many procedures have came. Some are in positive recommendation, some has gone to a negative recommendation. So it is there that some procedures nowadays are not performed. For example, IDET. It has been found that IDET is having more risk than benefit. That is why nowadays we are not doing IDET that much. Okay. Similarly, some procedures we are doing nowadays also. Ozone nucleolysis again gone into the disfavor. So depending on time, lot of the procedures are coming and they are going as well, and newer procedures are being invented like the biacoplasty, which is being, or posterior annuloplasty, which is being done today also. But the most common is the epidural steroid injection that is commonly performed in case of the discogenic pain. Now coming to the disc prolapse I have also discussed, because without this discogenic component we cannot discuss clearly. So in the disc prolapse, the most common treatment is definitely what we perform is the epidural steroid injection, which can give short to medium term pain relief. In some patients, if the component of mechanical compression is less, it can give a long-term pain relief as well. And there is epidural neuroplasty, there is percutaneous discectomy, ozone nucleolysis or transforamental ozone injection. I am discussing all those, but remember, it is not that all are commonly performed nowadays. Some game and some are now gone into disfavor because the other procedure is giving more benefit like that. Okay, but surgically we can go for the discectomy, laminectomy or fenestration. So these are the ways to manage the prolapsed disc. But also I should state certain things. Whenever you are seeing patient, you should not see the patient that this is my patient. The patient is a patient only. Okay. So if the patient requires a surgery, if you feel, always give your friend a referral, or you can send to the patient for the surgery, because ultimately the patient's benefit is what we require. We do not want an unnecessary surgery, but we do not want a necessary surgery is not performed. That is not also our part, important part to do. Next, coming to the sacroiliac arthropathy. Now, sacroiliac joint is situated in either side of the sacrum, where the sacrum is joining with the ilium. It is again a synovial type of joint. The upper part is mostly fibrous and there is the cartilage, and then the lower part is mostly the synovial portion. So, inflammation usually affect the lower part of the disc. So in sacroiliac joint arthropathy, pain will be in the low back, in the buttocks, hips, groin, and often unilateral. It is radiating, may extend to the thigh, but rarely goes beyond the knee. In the aggravating factors, pain worsens with the sitting, standing, in stair climbing, or changing positions. There is tenderness over the sacroiliac joint. Then there is stiffness in the lower back and hips sometimes may be found. And here there are certain tests like the Faber test, Glenson test, compression test, distraction test that can actually trigger the pain of the sacroiliac joint. Now, what are the treatment options we have? Injections like the corticosteroid injections, radiofrequency ablation for the sacroiliac joint, though conventional radiofrequency success is comparatively less, so we prefer either a cooled radiofrequency or a cryoablation. The result is comparatively better because they can cause a larger lesion, or we can go for a fusion surgery for the sacroiliac joint. Okay, nowadays in the West that is a very common surgery, but in India it is not that common even today. Next, going for the lumbar canal stenosis. With the aging, with the degenerated spine, there could be possible compression at the spinal nerve root. So what happens here? Usually with aging there is disc height reduction. Now what happens to the ligamentum flavum? They become loose and lax, and now they comes towards the anterior side, compressing and coming over the root. But this compression is not always the same. It changes with the position. When the patient is usually standing erect, there is usually more of the ligamentum flavum bending anteriorly and causing more compression at the spinal canal. The patient is leaning forward. Usually the posterior elements including the ligamentum is stretched tightly, and that is also causing less compression. So it's basically a dynamic compression based on the position. Now what happens with this condition? The patient usually suffers from the back pain. Now this pain is such type of a pain, unlike the others, this pain is not always the same because it is causing a dynamic compression. So what is happening? Usually when there is the patient is resting, there is no pain. Patients usually starts walking, then the pain starts, and after few meters, depending on the condition of the patient, maybe 5 minutes, 10 minutes, the patient feels the leg is heavy and now the patient needs to sit, or the patient stoops forward, okay, and then the pain is slightly relieved. So it is known as the shopping cart sign. That means someone holding the shopping cart that the pain is relieved, and this is known as the lumbar canal stenosis. This is one of the most common complaint for the older age group patients, okay. So what happens here? Usually there is leg pain with weakness and numbness which occurs during the walking. Pain is relieved by the sitting or leaning forward. Symptoms usually bilateral. Standing or walking worsens pain while lying down, or sitting improves it. Patients often lean on the objects or bend forwards to reduce the discomfort. Okay, so this condition is known as the lumbar canal stenosis, affect the aged individuals. So in a nutshell, this is very important chart to understand. Low back pain may be with radiation, may be without radiation. Okay. When it is without radiation, it could be axial or paramedian. With radiation, it could be a global radiation or it could be a patchy or segmental radiation. When it is an axial pain without radiation with low back pain, the possibility of discogenic low back pain is more. Axial pain without radiation could be caused by the compression fracture. Low back pain without radiation, paramedian pain, could be because of the facet joint arthropathy, it could be because of the sacroiliac joint arthropathy, or it could be because of the myofascial pain of that muscles. Low back pain with radiation, with global radiation, non-dermatomal radiation, could be because of the complex regional pain syndrome. Low back pain with radiation with segmental dermatomal distribution can be caused by the disc prolapse, and low back pain with radiation with non-dermatomal distribution can be caused by either piriformis syndrome, or sometimes it is non-dermatomal referred pain from the facet of the sacroiliac joint. Remember, unlike the radiation of the radiculopathy which goes along a dermatome, facet and sacroiliac joint pain sometimes can give a radiating pain which is a non-dermatomal type of referral, and that could be a pain with radiation and non-dermatomal distribution. Okay, so these are the usual shortcut, but remember the patient do not comes with these standard formats. Okay, so some from this area, some from that area will come to you, and you have to solve the puzzle and find out what could be the most possible cause of the pain, that is the provisional diagnosis, and what could be the differential diagnosis. So what we need to learn the steps of the evaluation. So let's discuss the steps of the evaluation. So at the first step, what we are going to do, we are going to find out the causes and find out the red flags. If the red flags are present, immediately go for the full evaluation, investigation and treatment. Okay, it could be surgical, it could be medical, depending on that. If it is not that part, definitely we have to go this diagram everywhere, but in those cases you have more time basically. So take a general history, take a specific history. On examination, do a general inspection, palpation, range of movement analysis, urological examination and special tests. Investigations, for the basic level you can go for the X-ray for the bony lesions, you can go for the CT scan definitely for the bony lesions. For the soft tissues, always better to have an MRI. Remember, ultrasound sometimes can be helpful in a only few number of cases, but as the spine is comparatively deeper, it is better to much better to go for the MRI for the soft tissue evaluation, and in certain conditions like an inflammatory arthropathy or an infection, blood investigations could be of help. Or in case of malignancies, if there is multiple sclerosis, definitely in those areas you can actually go for the blood investigations, that could be helpful. Or it could be helpful to rule out the other conditions. Now we can go for the diagnostic interventions like the nerve blocks, joint injections or trigger point injections depending on the case to case basis. So in general history, first we have to take the chief complaints, history of present illness with the intensity, quality, aggravating relieving factors, neuronal variation. You have to take the family history, like the inflammatory arthropathy could run in family. You have to take the medical history. You have to take the personal history. Usually the smokers, sedentary habit, manual laborers, they are more prone. You have to take the occupational history for them also. So they will get some clue from the general history part. Now we'll go for the inspection, palpation, range of movement analysis, neurological examination and special test. So in the inspection, check for the posture, check for the gait, check for the muscle size, shape, contour and color of the back and limb, presence of any swelling or scar. So I'm not going into much detail because these are the basic pro forma of the examination which you do for the all cases. It is not for the back pain. Now we have to palpate. Here we have the certain specific areas of palpation, like we have to palpate specifically on the joints, specifically on the ligaments if you are suspecting pain is taking origin from the ligaments, and for the myofascial pains we have to check for the muscular pains, and if you are thinking that it is coming from piriformis, you have to area check and palpate over the area of piriformis or sacroiliac joint. Depending on the area you have to palpate, but definitely palpation gives a good clue. Even sometimes what we do, apart from the palpation what we do in the OPD, sometimes we take patient under the fluoroscopy, and here we can palpate actually in a AP view and try to find out the bony structure underneath what is causing pain. So in that way our palpation becomes much specific to a specific area, especially if the facet joint pains can be picked up better with such a under fluoroscopy palpation. So that is another way to find out the pain is originating from the facet joint. Now range of movement analysis of the hip and spine. Remember, sometimes hip pain can be confused as a back pain. So in those cases we have to check for the movement of the spine and hip as well. In case of spondyloarthropathy, it could be restricted. In case of avian hip or in case of hip OA, it could be restricted. Then flexion, extension, rotation, lateral extension, we have to check and we have to ask whether the pain is reproduced or not. And abduction, adduction of hip, we have to check as well. Neurological examination, we have to check for the higher functions, cranial nerve examination, examination of the both upper and lower limb, sensory and motor. So these things what we have learned in our UG days, we have to check in the lower limb. Okay. Now special tests, we have to having special test for the lumbar nerve root irritations. We have the special test for the canal stenosis. We have special test for the sacroiliac joint pain. We have special test for the piriformis myofascial pain. So we will come one by one. This is the simplest test. So usually we take the patient, we check for the power of the limb, we check for the extensor hallucis longus power, we also check the plantar flexion as well, and after this we do this test as well. This is the straight leg rising test. So passively we are extending the legs to 60 degree. So if the pain reappears and it increases along the dermatomal distribution, it is suggestive of the taking origin from the nerve root. Next, just one second. আরে ক্লাস নিচ্ছি এখন পরে পরে কথা বলবো ওকে তো কালকে দিলাম ফোনটা ওকে now test for the spinal canal stenosis. So here we can go either for this test which is known as the Stoop test, or we can go for the Kemp test. Remember, facet pain and the spinal canal stenosis pain both can be increased by the Kemp test. So basically it is the extension, and the Kemp test is basically extension and the lateral bending together combined. So pain can be increased both in case of facet and in case of spinal canal stenosis, but in facet it could be more of a pain at the back, but in spinal canal stenosis it should be back along with the leg. But only with that you cannot be able to differentiate. We can take the help of the Stoop test or the shopping cart sign. In the Stoop test, the patient is asked to walk first, then the patient is actually asked, when the patient is not able to walk in the straight posture, ask the patient to stoop forward and then walk. Usually it gives a little bit relief on stooping, so that is also signifies the pain originating from the spinal canal stenosis. Now there are a number of tests for the sacroiliac joint, like the Glenn-Slens test, like the compression test, like the Faber test, like the distraction test. So we will not be discussing Yeoman's test. There are multiple number of tests, but common tests I will be showing to you. And you have to check for the piriformis syndrome and myofascial pain as well. And you have to do the advanced techniques as well. Okay, the advanced techniques I will discuss a little later. So but first let us show you a few common tests what we commonly perform. Okay, so let's be back, and I think nothing will be required. Just give it to me. Okay. I'm just changing this. Okay, fine. Hope we can see the examination table. So the first special test what we perform. Shoja. So usually when the patient comes, we usually check for the straight leg rising test. For simple, just very clinically, very thing. Just put it here. If there is severe pain, the pain will start from here. Maximally you can take it up to here. After this, even though pain comes, it has not having much significance. Okay, and usually it should be a pain which is type should be neuropathic, and it should be a dermatomal distribution. Okay, so and we also check for the power for the extensor hallucis longus, comparing with the other leg. Ask the patient to raise the toes and then press with your hand from above and below. So if the patient is unable to move this above, most commonly the L5 is affected. Okay, if the patient is unable to move the limb like this, most commonly S1 is affected, and this can also be examined in another way, asking the patient to walk on the heel and walk on the toe. Remember, patient with the S1 radiculopathy won't be able to walk on the toe, and patient with the L5 radiculopathy won't be able to walk on the heel. So in that way we can test the power in the heel to walking as well. Next we can check for the sacroiliac joint. For the sacroiliac joint we can go for the compression test like this. Okay, or distraction test like this, or more commonly what we do is the Faber's test. So what we do, it is the flexion, okay, then it is the abduction. So simply we are putting the leg like the figure of 4 of English, okay, and then we are holding one hand here to the opposite hip, and then we are pressing it like this. Okay, so if the pain appears at the back, it is usually suggestive of the sacroiliac joint pain. Remember, it can happen that adductor tendonitis could cause pain in the same posture in the anterior side of the hip. So that could be result from the adductor tendonitis. Now for the piriformis, how we can stretch the piriformis? Basically we can do the flexion, adduction and internal rotation. So basically with this maneuver we are stretching this muscle of piriformis from here to here. So basically when the piriformis is stretched, the piriformis syndrome pain will reappear. So in that way we can provocate the pain of the piriformis syndrome as well. And sometimes we also do other tests, like go back. like this, we can actually hold it and then take it like this. That is also putting a stress over the sacroiliac joint, this sacroiliac joint, and this is known as the Yeoman's test. That is also very specific test for the sacroiliac joint. Or we can do the Glenn-Slens test as well. But remember, these are the most commonly. You cannot be able to do all the tests in your clinic, but at least do a Faber. If you want, do an Yeoman or compression destruction, which can be easily done. So by that way, if it is positive, it could be suggestive of the sacroiliac joint pain. Then palpate the area of the sacroiliac joint, palpate the area of the facets. These are also very important. And if you will see some patients and it will be clear, if it is exactly pain is at the central, it could be most commonly a discogenic pain or a bilateral facet pain, or if it is just slightly by the side of the spine, usually it is originating from the facet, and further lateral in the erector spinae group of muscle, it could be originating from the myofascial pain. Okay, so these are the easier ways, but sometimes they are a little bit confusing, like the L5S1 and the sacroiliac joint pain, they are supplied by the same nerve. So sometimes it might happen, they appear clinically the same, but when you examine later, it will be revealed actually from which structure the pain is originating. So these are the common special tests and that is commonly performed. So I am not going into the rarer tests, there are a multiple number of the sacroiliac joints, I am not going into that, but these are the usual tests. Do you perform all blocks in one sitting or separately? Remember, there is a question someone asked that do you perform all the blocks in one sitting or separately? So there is a way. In fact, for example, in some patient, you are suspecting it's a facet pain. So go the facet pain intra-articular first. So if it relieves, it is fine. Then we can go for the selective nerve root blocks. So in that way, you can go in one sitting some blocks, but not all the blocks. Because if you have done first the selective nerve root block, then doing facet pain is not possible. So you will learn with time which blocks you can do together and which blocks we cannot do together. Okay, and if you have to do a few blocks together, which block is to be done first and which block is to be done next. Usually the more superficial blocks, like if you are thinking myofascial pain, usually we should first go for the myofascial pain, then we should go for the facet, then we should go for the nerve root, like that. Okay, so we have to go in a graded way so that one block's result will not hamper the other block's effect. Okay, so that we should remember while we are going to do these procedures. So we have just covered most of the things. So if you have any question, we will discuss, because here I am sure they will be having multiple questions, because this is the most practical part, and I will welcome all the questions and I will like to answer all the questions as well. But before that, just a few procedures that we perform, advanced procedures, that let us discuss those as well. So this is one technique which is done for the failed back surgery syndrome or a resistant radicular pain, or sometimes a complex regional pain syndrome, which is known as the spinal cord stimulation. It is a neuromodulation where actually some leads are passed, and based on the gate control theory, we can block the pain sensation by stimulating the high diameter nerves. Basically, we can actually stop the sensation from the A delta and C fibers by blocking the A beta fibers. Okay, so that is how it can be done. So this is the steps of the spinal cord stimulation that we'll discuss. Then for the vertebral compression fracture, we can go and with the needle we can fill that fracture with the bone cement, and that is known as the vertebroplasty, but also in a part of the advanced pain management techniques that we commonly perform. And definitely there are multiple other things that we learn throughout the course. Okay, now if you have any questions, I will welcome that, and then I will go in for a quiz. Any questions? Those who have written in the chat, I have answered, tried to answer at least.
Sir, are there any regenerative procedures for disc?
See, like PRP in the disc, VMAC in the disc, they have started. But as long as they do not come into the mainstream, we're not going to discuss those. Yes, some physicians are doing, but again, they are mostly study related. They are not for they came as a clinical treatment. Okay.
Okay.
So nowadays, those who are that is happening is related to a study.
And what is the dose of steroids, sir, for if
That
we,
will come. Individual doses with the individual procedures will come for in every area actually. Okay. We have next classes for that.
Sir.
Okay. So let's start with the quiz. So are you everyone know about the quiz.com? Those who are playing for long, they knows, but those who are new, they I say. Just go to the quiz.com with your mobile or computer, whatever. Quiz.com is available in both. Huh? So you
Link.
will
Lovely fork.
unless you want, so no issue.
Freak boy.
I will request everyone to join. Okay.
Jolly. Toilet IQ. Clever IQ. Sir Wasp. Lady Ice. Bouncy King. Jolly Man. Clever Hyena. Max. Dr. Police. Lucky Street. Lady Hyena. Quick Pig.
Please join faster, everyone, please.
Dr.
Dr.
Stan. Backwards.
code is not
How
working?
to join? How to
Invalid
join
game code.
quiz.com?
Okay, very good
Rubbiting.
question. If anyone is having question,
Uncle
please
Flower.
ask.
Mr.
Toilet
House.
House.
Jolly
Go to the
Data.
quiz.com. Just put this pin code,
Brother PRK Man.
okay?
Mama Cow.
And your name will be anonymous. You don't have to put your name. Just search the Google with quiz.com or scan this QR code that will also work.
Miss Cactus.
Either scan this QR code or write quiz.com and then
Madhu
paste
Dash
and then put this
aimbot.
pin code.
Okay, sir. Thanks.
So requesting all to join because it is enjoying first of all, and also you will know that how much
AB
you are doing
Fluffy
well.
Hyena. SVK Pain. Slow Cactus.
Okay, so let's start. Anyone is trying to join but not able to join, then I will wait. Otherwise, I will start. Okay, let me start. Yeah.
Uncle Police. Random Lion.
So the number will be there at the top even when it is being played.
Bouncy Flower joined. Play and create.
Which of the following is considered a red flag in the evaluation of LBP? Fever with back pain. What is a common feature of pain from facet joint arthropathy? Pain on extension and rotation.
Quick Man joined.
Which diagnostic tool is most useful for identifying discogenic pain? Provocative discography. What is a characteristic finding of internal disc disruption, IDD? High intensity zone, HIZ, on MRI. Which of the following is a test used for diagnosing piriformis syndrome? Fair test. What is the primary characteristic of pain in disc prolapse? Leg pain greater than back pain. Which is not typically used in diagnostic interventional pain procedures. Disc biopsy. A negative straight leg raise, SLR, test most likely rules out which condition? Disc prolapse.
Final question. Double points.
Which of the following correlates poorly with imaging findings in LBP patients? Psychological factors.
Third place. Foolish aimbot. Second place, Lady Hyena. And the winner is Sir Wasp.
Hello? Hello?
Yes, audible.
Who is
Hello.
this? Who is the Sarva?
Hello.
Hello? Yes.
Hello.
Yes, sir.
Okay. Who is this? Dr. Shiva.
Dr. Shashidhar.
Okay. Congratulations to you.
Thank you, sir.
So there will be some questions and MCQs in your app as well. You should see the recording, and I have already given the study material as well. And then you can actually attempt those questions as well. And video will be uploaded tomorrow during the working hours, okay? Because usually it takes around 1 hour for the processing, and then it is uploaded in the next day.
Sari, can you please upload your PowerPoint presentations as well, especially
See,
about
this
the
is the
radio
study
frequency?
material. Whatever we are telling, we are including in that study material, okay? Along with some important slides definitely there. Because what happens in PowerPoint, some presentations remains which are copyrighted material that we cannot share. So excluding those copyrighted material, most of the things we shared in the study material. Okay, you check, I have already shared the study material, which includes almost everything what I have told you.
So can we download the study material?
It is available for
Can
you,
we take printouts?
for the lifetime for Asian Pen Academy, okay?
Okay.
So we are not deleting it, it will remain forever. Forever means lifetime of the Asian Pen Academy, that can I tell. Well, as
Thank
long
you.
as the app is there, your access will be there.
Yeah. Thank you.
Sir,
Thank you.
The recording,
this is it
the
is there,
record-
but
yes.
sorry to interrupt you.
Yes.
It is there, but it is not a printable form.
Actually, they are actually changed and modified to a, it is not directly this form because we are uploading directly to this app. Okay, that is why it is, and it is modified by the app according to the fonts and the markings, they are changed according to the mobile version.
Sir, I have a doubt from previous class. Can I ask?
Yes.
Regarding the procedures like what do you say, lateral epicondylitis, medial epicondylitis, and
Yes.
stellate ganglion block. For those procedures, what is the dosage of the drug and volume of the drug we have to give?
Okay, in most of the classes we have already discussed, but for stellate ganglion, it depends on that where you are doing. If you are doing at the level of the C6, usually it is something between 10 to 15 ml. If you are doing at the C7 level, it is something between 5 to 10 nml because you are closer to the ganglion. For the lateral epicondylitis, medial epicondylitis, this requires really a small volume of PRP or steroid. In fact, usually we take it in a 2cc syringe and we inject that PRP with that area. Okay. So volume is something 1.5 to 2 ml maximum. Okay. Even in some cases we give more concentrated, then we can reduce it to 1 ml as well. Okay.
Okay, sir.
Depending on area, that there is slight change in the volume and patient also.
Okay, sir.
Okay.
Thank you, sir.
So let's say goodbye for today.
Yes, sir.